We have had a lot of drugs being approved in myeloma. The immunotherapies just keep on coming. We have had 3 bispecific drugs approved in America in less than 24 months for the disease. These drugs by themselves, I would project at least 5 years of survival for the average patient, which is amazing. Also using some of the drugs that we have had for a little while in new combinations have led to new approvals. And the Isatuximab with the old drug Bortezomib and Lenalidomide and Dexamethasone was approved also in 24, very recently. I was the discussant at ASCO in Chicago of 2024, where I was asked to review the presentations focusing on newly diagnosed patients in myeloma. And of course, the presentations included all these new combinations. So I had to read up a lot and prepare. What was striking to me was that you can now see that these new antibodies can deliver very deep responses that seem to be very durable, independent of transplant status. So in 1983, the field came up with the idea of transplant-eligible and transplant-eligible and transplant-ineligible. But if you look at the new data from studies, you see in both those groups of patients that these new combinations deliver the same magnificent results. So I asked at ASCO, as part of my review as a discussant, why do we still talk about this old terminology of transplant eligibility when we have the same results either way? So basically we have very effective drugs that can be given independent of age. They're highly tolerable. The Isatuximab-VRd at this time, when I'm talking here today, is the only approved 4-drug regimen with a CD38 targeted antibody for the transplant-ineligible population. Daratumumab has not yet been published, but here at IMS there will be a presentation on the Daratumumab, also with Bortezomib, Lenalidomide, Dexamethasone. And I think it's very likely that the data is probably already submitted to the FDA, and they are probably reviewing it. And I would expect, assuming that the data is positive, which I have no reason to believe otherwise, I think it's going to show very similar results, that the FDA will probably approve that also. So then we have 2 options to choose between. And people are asking, should you use Isatuximab or Daratumumab? I think there is no randomized trial to compare the 2 of them. So we don't know if there is a reason to pick one over the other. I think it's probably a lot of preference. And I assume around the world that there will also be access differences. So some drugs may be easier to get access to in some parts of the world. So we don't really have scientific data to judge yet.